Welcome back to the Cake and Pie Expo. So happy you're here. So before me today, I have this traditional Mai Sung Vietnamese candy, which is sesame seed coated. It's from Hue. It's really delicious. And the thing about this is, I forgot to take a bite. Just checking. It is absolutely awesome. Which is great, because we're here for the RETINAWESOME session. Welcome. So I'm going to take you through a bunch of the different talks to get you acquainted with what's going on. First up, the LM inverted flap and stuffin technique for traumatic macular hole by Dr. Hudson Nakamura out of Brazil. Second, tackling macular hole with epiretinal membrane by Dr. Vaibhav Sethi in India. Third up, macular hole in myopic patients with associated retinal detachment by Dr. Waiching Lam in Hong Kong. Fourth, chronic traumatic large macular hole by Dr. Saad Waheeb in Saudi Arabia. Fifth, a drop nucleus that went subretinal and the way to remove it by Athanasius Nikolakopoulos. And by the way, that speaker was from Greece. We have a panel discussion at the end, which is going to be amazing. Stick with it, and here we go.
Yeah, good morning, afternoon, evening, everybody. It's a great pleasure to be here in the RETINAWESOME Cake and Pie. And I'll have the pleasure to show Athanasius Nikolakopoulos video on
I'm always doing by manual whatever I'm doing in the eye. And this is a bullous detachment that I saw when they asked me to remove a nucleus, but I didn't find the nucleus. And the nucleus was sucked from this huge tear. And you see that I'm going with a fluid needle, opening up the hole, and then I'm trying to remove it, and you see that the nucleus is bigger even than the hole. The hole is somehow the retina is elastic. The question is, how can this huge nucleus go through a tear that it was made by the surgeon who was trying to survive and trying to remove it by fishing for the nucleus that it was ready to drop in. And people that they try to fish it out, they have this problem. A take-home message is how to remove it now, because you are in the middle of the eye and you have a retinal detachment with a hole at the side. So if you do things that you shouldn't do, you'll destroy retina. The trick is not to touch anything in the nucleus that is sitting on top of the retina. Whatever we have to do it away from the retina. So we have to suck it up and try to catch it up by manually, try to break it. It's very, very strong. The patient was 87 years old. It's a very strong nucleus. You cannot crush it very easily. So we use endofragmentation for that. That's another trick. When you use endofragmentation, the sucking power is huge and the infusion is less. So sometimes you get a collapsed eye. So you have to control it, and you have always to keep the port closed, and you can use the other hand to actually push the nucleus against the suction of the fragmentation, and you cut it round in shapes. The other point is that all these fragments that they go and they hit the retina while you're trying to remove it, nothing is happening to the retina. No damage is done to the retina by flying fragments. And then I used to do this injection of gas and try to flatten the retina. And because it's a huge tear and it's almost a quarter of the eye, it's about 6 to 9, something like that. We have to, I was ready to put some gas in it. And then I saw that it has also a descemet detachment. And if you leave the descemet detachment, so I use the roller steamroller technique. I put a gas bubble, air bubble, and I push the descemet back, and then I cut a suture through and through in order to save the cornea from haziness. And the take-home message for this is, first, when you drop something, don't try to get it out. Whatever is behind the iris, leave it there. Second is remove everything that's anteriorly to the iris. Don't let any vitreous. Third, don't use any perfluorocarbon. Don't use any viscous fluids for that, because they drop at the back of the eye, and the only thing they do is raise the pressure and have a white cornea. The third thing is, don't try to touch anything that's sitting on the top of the retina. Anything that you're touching and you want to remove it, if it's a foreign body, if it's a nucleus, if it's anything else, you have to lift it in the middle of the eye, and whatever movements you're doing, don't let things sitting on top of the retina. As a matter of fact, this is a very, very true thing, that you shouldn't try to fish it out. So fishing a nucleus while it's ready to drop, better leave it down there and we'll take it very easily. Otherwise, we have to fix things that they're going to be damaged by the surgeon. I think that it's surprising for us, and I hope it's surprising for you, and its take-home message is strong. Thank you.
Yeah, great case. And I've done a couple of these cases in the last 2 months. And this is a hard decision whether to remove it and to finish the procedure with air or silicone oil. What are your thoughts on that, Athanasius?
Well, I missed that. You said to remove it or not to remove it? Because we have to remove it. There's no problem.
Yeah, I know, but you end the case and you leave either silicone oil or gas, or you PFC oftentimes.
In this case, I never use PFCL, because as I told you, when you want to remove fragments and you put PFCL on the bottom of the eye, and you used to lift this a little bit further up in order to protect the retina from the nucleus fragments, the only thing you do is, as soon as you start the vitrectomy, the PFCL is going on top of the fragments and is pressing against the retina. So you don't need to use PFCL, just suction systems to get it in the middle and by manual surgery. And the other thing about what you use, in this case that has a huge tear, gas is very, sometimes it's difficult because it might get under the retina very easily. And if the surface tension of the tear in a fresh detachment like that is less than the surface tension of silicone, I use silicone oil for this, because silicone oil wouldn't go behind it. But if you put gas under pressure, not the soft gas we use to put just to exchange fluids in order to have a complete fill, there's always a possibility for the gas to go behind, and then you find yourself trying to remove the gas behind the retina. But this is only to this particular case. If it's a fresh detachment, I use gas. But in this case, I use silicone oil in order not the gas to go behind it, and I feel safer this way.
Yeah, sometimes you have to do what makes you safer. Great case, and lots of discussion on that and decisions, but very cool. And it's so rare to have the thing just behind the retina, so that scares us, but you managed it the best way. Congratulations.
Well, I've been accused by people that I put it myself behind it in order to make it a rare case, but that's not the point. It's always a question how it got behind. The system is, it must be, the eye has to be deflated so much that the retina was tear up by trying to catch the vitreous, and then opening the hole, it was just a negative pressure that when he get inside and he was blocked inside. That's the only reason I can see. But this is the result of trying to fish the nucleus near the base of the eye. You produce giant tear sometimes.
Very cool. And we proceed. It's an honor to have here Dr. Saad Waheeb to present his case. And you have your case ready, Saad?
Yes. So I'm just trying to share the screen. Can you see my screen?
Yes,
Can you
it's
see the screen?
really good. It's
Okay.
large and well shared.
Yeah, thank you. Well, thank you, Hudson. Before I start, I just wanted to say one quick comment to Athanasius. I think he presented a great case, and I cannot agree more. I was doing a webinar with some anterior segment surgeon, and they insisted on putting a pars plana vitrectomy trocar and fishing for a dropped nucleus, and I cannot agree more. That an anterior segment surgeon should just clear the anterior segment, may put the IOL, and leave the rest for a good, clear three-port vitrectomy by a posterior segment surgeon. The other thing also I wanted to say something about PFC. I think it just makes the surgeon feels comfortable. I agree. I have never seen damage from a dropped nucleus to the retina, but I think people tend to put heavy liquids because I think it makes them feel comfortable. But that was a great case, Athanasius. Okay, so I'm going to take you through my case. This is a younger male who came to see me as a referral, who had a history of blunt trauma to his left eye a couple of years ago, I think 2 or 3 years ago. His vision was poor in this eye around counting finger, which is his left eye. And you can see from the photos, he has a large macular hole with an overlying chorioretinal scar that looks like an old choroidal rupture. The rest of his examination was normal. And, I sat with the patient who did an OCT that shows quite a large macular hole with a basal diameter of 1,200 and an apical diameter of almost 800. And, I did discuss with him the possibilities of multiple surgeries, and we agreed, and we went on for his vitrectomy. And this was a 25 gauge 10K beveled vitrectomy. And of course, the patient is phakic. And in these cases, when you're doing the vitrectomy, this was a core vitrectomy, as you can see. As I started the vitrectomy, there was some white stuff that you'll see. I think it's just the old maybe hemorrhage or the operculum of the hole that has happened. But you want to be careful when you're doing vitrectomy for these patients, because the vitreous is usually very tight, and it's not easy to induce a PVD. And in these cases, I usually use triamcinolone assisted vitrectomy, because it does make the view of the vitreous clearer and allows me to do a safer posterior vitreous detachment induction. After cleaning the triamcinolone on the surface of the retina, which is happening now, I went in to try to induce a PVD, which was not easy. You have to try a couple of times, and I always teach the fellows with me that you get closer to the edge of the disc, and then you apply vacuum until you feel that you have a good grasp. Once you have a good grasp, then you pull to the top and tangentially. As you're seeing here, I'm trying to catch the edge of the vitreous, and you can see the wave spreading, which is very classic in these cases. Once you get the edge, then you invest on it and you spread more. You allow fluid to go behind the vitreous to detach the PVD better. In these cases, I don't usually take the posterior vitreous detachment very far. I'm very comfortable just detaching around the vascular arcade and before the equator, because the pathology is really in the macula. And once you do that, as you can see, trying to clear the rest of the posterior vitreous detachment, and then taking it a little bit further. Of course, you pay attention to the retina as you do that, because sometimes if you apply a lot of suction, you might induce retinal tears. And I usually, if I see any petechiae or any hemorrhages on the retina, that usually indicates that I'm pulling too much and I need to ease in the pull. And then I use membrane blue to try to stain the ILM. And in these cases, sometimes you might have to stain multiple times. But I was lucky in this patient, and we stained only once. After you leave it for a while, you start to catch an edge wherever you try. What I'm trying to do in this case is to try to do a fovea sparing ILM peel. I tend in these large macular holes not to peel all the ILM, because just in case if it does not work and I come back, I can get a free flap and cover the hole. So I'm trying to be conservative with the ILM, but I'm trying to hold it. As you can see, what I'm doing here in this fovea sparing is I'm trying to do the envelope technique, or as they call it, where you're trying to remove the ILM from different sides, and then you cover the hole as if you're covering an envelope. So one layer on top of the other. And that's what I'm trying to do here. Of course, you frequently re-grasp it, just like you're doing a capsulorhexis with the anterior segment, and then you flip it on the surface of the macular hole. And then what you do, I'm going to do this in a second, you get your cutter and you try to trim it. Now, I learned this the hard way. When you're doing this, please lower your vacuum, because if you don't lower your vacuum, you run the risk of detaching the whole ILM. And unfortunately, it happened to me before. If you use high vacuum, when you're trying to trim these edges of ILM, then the vacuum will just suck the whole ILM into the tip of the cutter, and you will just detach. So you lower your vacuum, and then I did air fluid exchange, which went very smooth. I usually either inspect the periphery through the vitrectomy, or I do an indirect exam at the end of the case. I think that concludes my video, and I'll just take you through the post-op pictures. The one on the right is the pre-op. The one in the middle with around 50% gas fill is around 10 days or 2 weeks. I use the SF6 gas. And the last one is around, I think, 3 or 4 weeks. Now, I do like to do an OCT within 2 or 3 days. And I think if the hole is going to close, it usually does close that quickly. And I have a good ultrasonographer or a technician who does a great job in doing this. And this is how the patient looked. Surprisingly to me, he did have a good improvement in his visual acuity. Within 4 weeks, his hole is actually closed, and his vision did improve to 20/50. And I followed this patient up for almost 6 months, and his vision remained very stable. Still some cystic changes, and I'm not seeing a major improvement in the ellipsoid zone, but I think it's recovering. And this is typical of these cases, and is what differentiate these traumatic cases, because usually they happen in young adults to the idiopathic holes that happen in elderly patients. I think that concludes my case. Thank you.
Very good job, Saad. It's interesting to see how you manage the ILM and you fold it. I do something similar, and except that I like to do this also under perfluorocarbon liquids as well. And I don't usually trim the edge of the ILM. I try to get the ILM, underneath the subretinal space, so it stays flattened. Of course, if it stays too folded, it won't be good. So I try to open this and insert, so it stays like flattened below. But sometimes you have to cut the ILM, so it's difficult. As you suction, you might damage the ILM. Sure. Have you tried doing that, Dr. Lam? Trimming the ILM before inserting into the hole?
Yeah, I think Waheeb did a beautiful job with the way that the ILM being released, and essentially it's like the inverted flap, but multiple. And I too like to trim it, because I found when you have a very large piece of the inverted flap, especially with multiple ones, then they tend to kind of tangle each other, and then post-op, sometimes you can actually see scrolled or extra IOM kind of excess in the area of the hole. Although after a while you don't see them anymore, but I think it will be better for the closure of the hole when you don't have the overlapping the flaps that might actually somewhat interfering with each other. By trimming it down, just making it a little easier for the hole to close, I think. But well done, Waheeb, for the beautiful. And I think, as you mentioned, because of the young age of this persons. That's why even though the ISOS junction hasn't fully recovered, he got a 20/50 vision. So
yeah, no, I
so
was lucky.
even,
I was lucky.
yeah, no, traumatic hole in a young person, definitely worth it.
Yeah.
Yeah, this is amazing. You know, the 20/50 and with the scaro there, and you see the hyperpigmentation and the hole closed, beautiful OCT. That's amazing. And I love the way you showed the vitrectomy, the staining there, you know, you got to see everything. And that was cool. Any thoughts, Vaibhav, on Saad's case? Or Athanasius would like to comment?
Yes, Dr. Hudson, I think it was a very well managed case. Such traumatic macular holes can be very tricky. It can go either way, you know, the hole may not close as well. And the size of the hole also looked pretty large. So one of the questions that I had for Dr. Saad is, would a large temporal flap going all along and beyond the macular hole and just flipping it like a dosa in India, which you call it, or you call it like a taco. So, you know, just placing it over, doing nothing to the nasal ILM, and just leaving it there with fluid air exchange and putting in gas. Would that also be a good technique? Have you tried that?
I did. I agree with you. I think there are different ways of doing it. You know, people just do an inverted flap. Some people do the envelope. Other people do the trapdoor. And I agree. I think it would have worked as good in these cases.
Yeah, very nice comments. And sorry for the issue in the first video from Athanasius, because I put the videos so side by side, it's very small, so I was not finding. So I probably needed an ophthalmologist to get my presbyopia checked, even though I'm wearing these multifocal contact lenses here. And next to present, and I'm here with your video, Dr. Lam, it's your case. Can I share the screen to show your case?
Sure, thank you.
So it is there. May I start?
Yeah. So you can hear me well, I assume. And so I picked this case is that you see macular hole associated retinal detachment only see in the high myopes. And at the beginning of the case, the subretinal fluid streams through the macular hole. And very often you see the vitreous membrane on the surface, and they are pretty tenacious. And trying to peel with single-handed is often difficult. And I found a bimanual peeling are able to stabilize the retina to peel. So after you peel the vitreous membrane, I stain the ILM, and here I'm peeling the ILM. Again, trying to do it with a single-handed fork. And I found that as you pull, the very bolus detachment will come with it and making it difficult. So again, a bimanual method using a diamond-dusted membrane scraper or the finesse loop will be helpful to scrape off the very adherent, in this case, the internal limiting membrane. But remember, as I mentioned, they often have multiple layer of vitreous membrane before you reach the internal membrane. So I try to remove the internal limiting membrane around the macular hole, and I don't go too far beyond the macular hole, similar to the explanation that Dr. Saad has mentioned about managing the traumatic macular hole. The problem is really in the area of the hole. So next, we have to drain. Now, there's often a question where you're going to drain. You drain through the macular hole, or you drain in another location. In this case, I decided to drain in an extrafoveal location. So you can see I pick a hole. I create a retinotomy in an area outside the macular hole. My rationale is if you drain through the macular hole, often the rushes of the subretinal fluid or the manipulations of the soft tip backflush can enlarge the macular hole. And that could potentially either damage the recovery of the visions or making the macular hole fail to close. So creating a small hole in extra foveal locations allowed me to flatten the detachment without manipulating the macular hole. I didn't do any flap. I didn't do any kind of stuffing of the IOM into the hole in this particular case, and just removing the IOM from the area. Partly because I don't know you have noticed it, the hole itself is quite small, and I feel that it's not necessary to go through that step in order to achieve a closure and reattachment. And then I just fill the eye up with C3F8, and I did not use silicone oil, and the case was quite successful at the end, a complete reattachment with the hole closed. However, I think if you have a larger hole, then it will be worthwhile to consider maybe doing a flap. And I don't like stuffing the IOM into the macular hole. I think that itself could potentially cause more damage and enlarge the hole itself. So, so this is just keeping in consistent with the theme of the rest of the presentation, that we're talking about management of macular hole, but in this case, when there is a retinal detachment, particularly in a case of high myopes. So.
Really cool video. And I was going to ask you, when you start the removal of the hyaloid, you see that the hole comes a little distorted. This is good to actually help to close it, I guess, because I like doing that when I remove anything from the surface of the retina. If that makes the round comes a little oval and start actually to close it, especially in those smaller holes, that helps a lot. And then you remove the all tractons, you remove all superficial elements, and you remove actually afterwards the ILM, and it works really good. And I agree with you. I like to insert the ILM inside the hole in such cases that the traumatic cases, such as the one that I'm going to show, and also cases where you have larger holes. But if you can put the ILM above and not to touch the RPE, that's a lot safer, of course, because if you go putting everything there, and so the likelihood of getting damage to the RPE is very high. So I'm very careful about it. What do you think, Saad?
No, I couldn't agree more, and I agree with what you said, and I like the case Dr. Lam was presenting. But I've got a question. Dr. Lam, any tips for these myopic macular holes? Because I have personally not been very successful, with these holes. And my question is there anything preoperatively that you see in the examination or on the OCT other than the duration that would make you say to the patient, I don't think we should go for surgery? Or do you operate on all of these cases?
I think you're right that in life, not all cases the same. And I think some will have better success. I think those with posterior staphyloma, especially if there is a lot of choroidal retinal atrophy in the area of the posterior pole near the macula or at the macula. Because at the end of the day, you need a healthy functioning RPE to keep the retina reattached. And in those cases, I think they will have poor prognosis. And the other situation is when the macular hole is large, especially when they're chronic. If they are relatively recent onset, then they will not, the hole can be quite small. And so those are the instances. And I remember a long time back, before we were doing peeling the IOM, I have tried to also laser around the hole to reattach it. light laser burn, but that will only work also when there is not a lot of atrophy, because if you have atrophy, the laser doesn't take. And so many times in those cases, I will use silicone oil. And I told the patient that you're stuck with the silicone oil, because if I take out the silicone oil, there's a very good chance that the macular hole will reopen and the retina will be redetached. I think, like I said, in those cases with a lot of atrophy, with posterior staphylomas, and that will be my kind of considerations to advise the patient the poor prognosis.
Yeah, thank you, Dr. Lam, for your comments. And I would like to call now Dr. Vaibhav Sethi for presenting his case, and his case, tackling macular hole with epiretinal membrane, by Dr. Vaibhav Sethi.
Thank you, Dr. Hudson, and great lectures and learning points from all the renowned doctors, and nice tips to learn. Every time whenever you have RETINAWESOME, we learn something new, and you can catch us with Dr. Hudson and on RETINAWESOME on YouTube as well. So my case, I'll just share my screen.
If you want me, do you have the smaller version? Because I have here, and I can share.
I just made a slight few changes, so I just shared.
Okay, that's fine. That's fine.
Can you see my screen?
Yeah, it's pretty good.
So the topic is tackling macular hole, another macular hole with epiretinal membrane. And actually the topic is slightly misguiding. It should be how not to do it, but still get away with it. So when you scratch too much, that's when you have a problem. And so retina behaves very well as long as you behave very well with it. If you don't, then it will misbehave. So this is a elderly 70-year-old female who had decreased vision in the right eye since 2 years. And the case I'll be presenting to you is a pseudophakic patient. And this was a long-standing macular hole secondary to a retinal vein occlusion after a cystoid macular edema. So the vision was right eye was 2200, and there's a full thickness macular hole with a thin ERM over it. So I thought it'll be a piece of cake. That's why I'm presenting in the Cake and Pie Expo. However, it wasn't to be. So the first mistake I made in this case was to place in too much of tricot. And I got my view a bit blurry. And actually, it would be better to place less amount of tricot. So however I got away with it, I cleared the tricot away, and I did a PVD happened very well. The other issue, the main issue that I'm going to be facing right now is I'm going to be using this flexi loop, which I've been using very often, and you tend to reuse these flexi loops somehow. So in this case, this is a reused flexi loop I'm using, and because in India there are some logistical and financial issues, so we kind of tend to reuse some certain aspects of instruments which can be done. And so the issue what I faced in this patient was after staining with the brilliant blue, there wasn't much of a dye, there wasn't much of a stain on the ILM because of the ERM. Of course, there was negative staining. And so I went ahead with this instrument. I tried to scratch as further away from the macula as possible. I was facing difficulty as I was not having a good view, but here, if you saw that, what happened here, I'll just show you what exactly happened. So after multiple attempts of scratching the macula and trying to peel off, trying to get an edge of the ILM, the mistake I made here, I had scratched too much. And I thought, and here what I did was I created a macular plaque. The fortunate part was it was quite further away from the fovea. So now my action plan changed. I quickly took it back, I removed it, and I went back to my conventional pinch and peel, which I think is the best technique to use in anybody's hands. So the other mistake I made here was when I was pulling the epiretinal membrane was so stuck that it actually pulled up the first fraction of the fovea, as you can see here. So that also was one issue that actually there was a slight pull on the fovea as well. But I tried to be as atraumatic and gentle as possible in removing the epiretinal membrane. The membrane along with the ILM came off, and I restained It didn't blue twice. However, there was just a little bit island remaining, which I was successful removing all across. And the last mistake I made was I tried to peel over a vessel. However, the fortunate part for me was it was a small vessel, so this there was a small creating hemorrhage, which I thought would be okay. So I carried on, tried to peel as much as I could. I did not have ILM. My initial plan was to do a flap. However, I did not have ILM left because everything came off with the ERM. So what I did was I drained and I dried the posterior pole as much as I could, bone dry, and put in gas and hope for the best. And I was lucky in this case that I did. This was the picture 1 month post surgery, the vision of 20/100, and this was the OCT picture. There was a closure. But however, maybe because of the long-standing nature of the hole, or maybe my manipulations, the ISOS junction has not yet formed. So I don't expect any more vision improvement. However, there are many learning points for me, and I hope everybody who's watching this video also learns what can be avoided in such cases. Don't do unnecessary steps. And the moral of my story was that stick to what works best in your hands. Thank you very much.
Congratulations, Vaibhav. And you see that you left the very foveal center untouched, and the OCT image is pretty cool. So you did a very great job. And sometimes we get those hemorrhages. And as I tell the residents and fellows, you've got to be very careful when you use a 23. I prefer to use the 25G cannula, backflush cannula, to actually remove those tiny little hemorrhages that get around sometimes when you pick the ILM. But so fortunately, they were far from the foveal area, and you did a very cool job. Athanasius, are you around to comment on Vaibhav's case? Yeah, go ahead, Vaibhav.
Yeah, I forgot to mention, I did not do anything to the macular break. I just let it be. I was too minded to do a row of laser, but then as previous teachings do tell us, you can leave it as it is, just put in air and gas, and fortunately everything was all right.
Yeah, that was cool. And
can I say something on that?
Yes, please.
Hello? Yes, it was a very nice presentation, and I had this problem sometimes with my hand, and everybody had it, but nobody says about it. Which tend to, the thing is with the flute needle, what I do is I just, instead of sucking, I flush it out. I first flush out the blood clots. They disperse into the vitreous, and then I suck it a little bit away from the, and this is a maneuver I'm doing when the blood is enough to do it. When the tiny blood clots and everything, I just leave them as they are. Of course, they have a little disturbance at the end when they disrupt and you have flies in your eyes and you don't like to have it. But if you like to remove it, I just try to do this trick in order not to suck it deep in the retina. But nevertheless, it's just, as you said before, is do what you do best and what instrument you have. So congratulations. It's the second time I'm looking at your videos and I'm always impressed. Thank you very much.
Yeah, I also want to comment, Sethi, that it is very nice of you to show like difficulty complications, because I think that what makes a good surgeon is how they managed complications and how they managed unforeseen events. And so that I think you have shown a very nice way to deal with situation that is unexpected. And you're absolutely right. When you use either finesse looped or the diamond dust scraper, you can accidentally tear the retina. And since there is actually no loss of retinal tissues, so there's actually no need to do anything other than just to leave it alone, and they will just nicely heal after like air fluid exchange. But you must do an air fluid exchange rather than just going to fluid, because in cases this happened with the ERM surgery where you may not routinely put in gas or air, then the edema and the swelling around the tear might accumulate and causing a small amount of subretinal fluid to accumulate. So I think it's essential to make sure that you do either do air fluid exchange or gas fluid exchange. And I think the hole closed nicely. Part of the poor vision is because if you look at the picture, you do have a central area of atrophy, and the OCT showed transmission kind of the scan. So with that amount of atrophy, it suggests the long-standing nature of this macular hole, and or there's already pre-existing atrophic changes. So I think not seeing the improvement of the visions is somewhat expected. So I think it was nice that you've done a beautiful job for closing that hole.
Thank you.
Yeah, really, congratulations. And as Dr. Lam said, I always try to tell my residents and fellows, don't do the thing exactly the same way you do this and that, because if you get a complication, you know how to direct it, how to go here and there. So it's part of the experience. And in the good hands of a good surgeon like you, the thing ends up in the good final result, as we saw in the OCT. But you see the OCT is the retina, the foveal area is thinner because of the atrophic changes, but the hole closed, and that was cool. Thank you very much. And last but not least is my case here, also on macular hole. I think today, though, the best case was Athanasius because he showed something different, but it's good that we talk about macular holes, and this could be called, as I was mentioning him, the macular session. And but it's very good to see those comments and how we deal with different things. So I will share my screen. And so this is the IBEG foundation, inverted ILM flap, and stuffing technique for traumatic macular hole with PVR retinal detachment. So we started the case, we set up for a 23 gauge vitrectomy. And as you see here, you have shortening of a retina, PVR, breaks. And I start first with the vitrectomy, core vitrectomy, peripheral vitrectomy, and go ahead with the air fluid exchange. As you see, the retina is totally detached. So I do a complete air fluid exchange and insert brilliant blue so that you see the membrane. As you see here, after injecting perfluorocarbon liquids, you see a bluish tint of the ILM. So it's cool. So I get the ILM from the temporal side and proceed towards the foveal area. As you see, I'm lifting here the ILM. And I'll stop there. I'll stop there and go the other way around, superior, to get the other half, I would say, of the ILM. So I stop there in order to have a stalk to hold the ILM in place. So I get the internal limiting membrane above, and then you see that the perfluorocarbon liquid weighs in on the retina. So if it escapes, you get the same part of the ILM. So I make the round movement, and actually the edges meet with each other at that place. And so I put, as you see here, very superficial. I'm not dipping into towards the RPE. So I get this and stuffing in an inverted fashion below, just underneath the hole there. And you see by transparency on the left side where this is actually, and you see the stalk is holding the stuffed ILM in place. In that way, avoiding it from coming out, and also the perfluorocarbon is playing that hole. So I leave it like that, and I'm going to work now to repair the retinal detachment. You see some tiny hemorrhage at the very periphery because the retina is very shortened. You have this PVR. I needed to do relief retinotomy, otherwise the retina wouldn't attach. And I concluded with laser, 2 or 3 rows, and in order to avoid any slippage of the retina, so I do a direct exchange of silicone, of perfluorocarbon for silicone oil. And you see the final bubble there. We gotta be very careful not to leave any bubbles there. And you see removing, and that was a nice case, and I'm still following this patient. He did not perform this post-operative OCT as of yet, but the first post-operative period, it was interesting that I could photograph this. The retina was still tinted. It was still bluish there, and the ILM was right there in the middle. And I usually like doing the stuffing technique for larger macular holes, but also for traumatic macular holes to get this substance, because sometimes, you know, often very many times you get this RPE maybe damaged there, but you have the structure of the retina damaged due to trauma. And so even though this was a 6 months trauma, and the patient had this hole, we still hope that he's going to get a better vision out of that. Thank you. Anybody would like to comment? My professor, Dr. Lam, I always love your comments, and we always learn a lot with you.
No, nice case, and you make the peeling the IOM under perfluorocarbon fluid looks easy. It is not so easy, especially if you don't have the experience, because the heavy fluid keeps the membrane down, and there's often a risk of pinching the retina with it. So of course, once you started, you will be able to find the edges, but to begin the case, often I find is not so easy. So you make it look very easy and interesting. And I think that it is possible to stuff it to the hole under the perfluorocarbon fluid without much trauma, because I think the heavy fluid assists you to keep the IOM in place, while if you don't have the heavy fluid, you will not be able to do that easily, and you might run into more difficulty, and then that will potentially causing some trauma to the RPE. And but as mentioned earlier, closing a traumatic macular hole can be done in many ways, either with just the inverted flap or with the technique that Saad has shown. And so I think that we realize that. So whatever works for the surgeon with the best kind of track record of what the method that he's or her is most familiar with is one that you should stay with.
Yeah, for sure. Thank you for the comments. And you know, the thing is, I love using these macular lenses, and I have a pretty good view from the posterior pole. So I see everything focused. So whenever the ILM escapes from the tip of the forceps, I can go and grab it without damage, because I'm seeing. And I remember you telling during our fellowship, I think you might have told also Saad that whenever you see something, you go and get it. But if you don't see, you don't get it. So if we see, we get it. And I think I've been doing this without perfluorocarbon liquids as well. And it works pretty good. But of course, as you said, you have a less of a control. So you gotta be very careful and more careful, of course, because you could go too deep and damage the RPE. So to get the things going and beautiful, it's better off not to go too deep. And many times the perfluorocarbon liquid helps you on that.
To my professor Lam, and also my
Yes.
professor, he's one of the best friends I've got, and to Hudson, for the viewing of what we have now, does any one of you have any experience with a 3D viewing with the new systems? They're not so new anymore, about the resolution and about the kind of viewing you have for the ILM with the 3D?
I think they're fine. Like we're using the Zeiss Adavo in our operating theater, and it is the viewing is just as good as under the microscope. And the convenience of that, of course, is that you don't have to bend your neck to watch the microscope eyepieces. So ergonomically, you're more comfortable. And but the view today's 3D viewing systems are as good.
But I have once we make another retina way, I got a 3D macular surgery in a 2D in order to be able to be presented. And the thing that I found out is that the resolution is so high that you can enlarge, and you have a magnification of huge magnification, like the similar you have a contact lens, and you can see details. And that's the biggest difference that I found, that you got a huge magnification without losing details. You cannot have it with a microscope, simply microscope. But your system, Zeiss system, is I think the most expensive one, because you have to buy the microscope and the system together. But it's always a happy time for me to see you, and I'm looking forward to drag you back to Greece, because I think you're avoiding us now that you went from Toronto to Hong Kong. It's a longer trip, and you're avoiding us every time we invite you.
Oh no,
not
no,
anymore. I'll come and pick you up.
Yeah, absolutely.
I'll
It's
come and pick you up.
worth every minute of it. I love the time that we spend there, and
But
the after teaching party is the best part also. So
get injected and come between 30th of August and 4th of September. Your name is in the program, so I already announced you without asking you.
Okay, thank you. Yes.
Very cool.
I'll work on that.
Athanasius, can you tell me how you teach in your lab, in your OR, the residents and fellows? How can you teach these 3D techniques and the settings? Can you go over how you prepare? How is your preparation for the surgeries to teach the residents? You see, I saw the pictures there, and I saw so many people there, and everybody is with one microscope. And for 3D, you have a special setting?
Yes, we have this. We are. They send us some ingenuity systems at the lab every time. And the trick is that everybody who wants to transfer his knowledge from microscope to 3D, he's afraid to touch the retina without looking at the microscope. And the more interesting tool we have in order to teach them is a bionico with a K, bionico eyes, which are artificial eyes with a ILM that they can remove. So they can get the training how to remove an ILM from an artificial eye. And these eyes are not so expensive because you can reuse them again. You can dye it again and do another ILM. So it's one after the other. And the trick is to show them that they can use huge magnification and they can manipulate, because in the beginning, there was a delay between the image and what you're doing with your hands. There was a small delay that was 80 milliseconds. Now with the new system, there's no delay. And the other benefit we teach them is that we have different colorings, different dyes, and different illumination. Viewing is a comparison between three things, between your peak. Do you know that every retina, every surgeon's retina has another peak in the wavelength? You can check your eyes. You can find what is your peak. And then you can find out what is the best light for what you're doing. It's yellow, it's amber, it's green light. And people have found out that the green, for example, light is much better for membranes than the red, what we say natural light. It's not natural, it's just the wavelength we're using. And also there are dyes that they're specially made for whatever. So it's a combination of your ability, dyes, and also the optical systems. Things are becoming very complicated in order to get the best visual result. And we try to get, like Lam, he has been to our school, and we have the best teachers in a man-to-man or student to fellow, whatever. In a base, we have 12 microscopes, for example, 12 surgical positions. And we don't have never more than 24 students to do that. So one day we train into ILM removal. The next training is for taking out foreign bodies. The next day is suturing the iris or whatever that. And it's a week, it's a campus. So we just train these fellows. And sometimes you see, it's surprising me how older people are coming because they want to know trips and ticks. That's why I appreciate how much you're doing, and you don't know how much offering you're doing with the Retina Awesome, because you don't show them regular things they can find in the books or they can find them in the videos. You show them tricks and tips how to face situations where they are thirsty, and you cannot have these on a book or on internet. So congratulations, we're doing the same job. I'm doing the live wet labs, and you're doing teaching to everybody else. And it's the easiest way. And every time I see what you're doing there, it's improving. Every time it's a different thing. And it's starting to become complicated for me because it's coming so many things, exhibitions, teachers, whatever. But it's something that I really admire. Transferring knowledge, which Lam is a specialist, is the best thing that I have seen. And thank you for giving me so much of your time. And I'm not going to talk anymore. Thank you.
Thank you. Great comments, Athanasius. We love your comments, and we learn with you. And it's an honor for us to be here. You know, that's the 11th event after the 10th, but it's not the 11th yet. It's the Cake and Pie Retinal Awesome. So for us, it's an honor to be invited from the Cake and Pie team to participate in the first Cake and Pie Expo. So this is an honor. And I'm pretty sure you showed the greatest cases and greatest discussions. And these ended with such a good comment from Dr. Athanasius. We passed just a little more time because we were allowed to do that, and it was good. So we could discuss a little more things. And I want to thank you very much. And I would like to ask Saad from Saudi Arabia, our friend, to wrap up this session and saying goodbye for all.
Thanks. Thank you. Thank you. That was a great session with very good cases and a lot of learning things, both from retina and from teaching points of view. I'd like to thank all the panelists, Dr. Athanasius from Greece, Dr. Lam, who's our mentor, and our professor, Dr. Sethi from India, myself, and of course, our great friend, Hudson Nakamura from Brazil. Thank you very much. That was great. We enjoyed it too much. Take care.
It was great to be with you, and waiting for you in the Retina Awesome 11. Have a great weekend, everybody.
Yeah,
Thanks,
quickly and very
Dr.
well.
Lam.
You too, enjoy.
Cheers.
You too. Bye.
Bye-bye.
Bye.
Bye. Bye.